Today we are going to discuss another important topic, that is flow cytometry in the benign disorders. So we already discussed the components and what are the principles, everything regarding the flow cytometry. Now we will discuss its applications, especially in the benign disorders. Okay, let's start. So in the flow cytometry applications, especially in benign disorders, again they are classified into RBC disorders, WBC disorders and the platelet disorders. So in the RBC disorders, again most of the topics we already discussed in its corresponding topics especially. So it's just more of kind of a revision. So I would like you guys to revise along with me. Okay. Then, so in the RBC disorders, the flow cytometry in the PNH and the flow OFT and the immunobinding test. And this is for which disorder? Yes, it is RBC membrane disorders. Okay. It is RBC membrane disorders. Yes, then there is a flow cytometry in the G6PD and the reticulocyte count, reticulocyte enumeration by using the flow cytometry. We'll discuss one by one. Then, so in the PNH, yes, this is again, as I said, it's a revision kind of class. Yes, I would like you guys to be active, right? So in PNH, what is the defect? This is the PIGA gene is the defective. And where this PIGA gene is located? Which chromosome? Yes, it is X chromosome. Okay, it is chromosome X. Okay, so what this PIGA gene will do normally? This PIGA gene, it codes for the, or it encodes for this GPI anchor protein. So this GPI anchor, what is the GPI anchor protein? It is nothing but it's a protein. It's a moiety. What it will do? Its function is to anchoring. So what it will anchor? What it will hold? It will hold a protein core. Okay, this is the protein which is anchored to this GPI moiety. This everything, this entire one is the GPI moiety. Okay, this GPI moiety is coded by the PIGA gene. Right, this is coded by the PIGA gene. We already discussed everything in the PNH clearly, right? This is a revision kind. Okay, so this GPI moiety, it is coded by this PIGA gene, and this GPI moiety, it anchors or it holds another protein core. And what are all the proteins that is holded by this GPI moiety? Yes, they are this list of these proteins, right? And the most important one are the complement proteins. Why they are most important? Because these complement proteins, regulatory proteins, that is CD55 and 59, what it will do? It will inhibits the alternate complement pathway. Right? It inhibits the alternate complement pathway, correct? So when this alternate when these proteins are defective, this alternate complement pathway will not be inhibited. So it is continuously damaging all the cells, which are all these leads to the features of the PNH, correct? So how the flow is useful here? We already discussed, right? In the flow cytometry, the basic ones. So in flow, what we'll do? This flow will use certain antibodies. They are fluorochrome tagged antibodies, and these antibodies, they will go and bind to their respective antigens, right? Nothing but proteins, right? So when this antigen antibody binding happens, when the laser hits these cells, then they will express the fluorescence, right? So that's the concept in flow cytometry. The same thing here, what we'll do in PNH. So these proteins will give antibodies against fluorochrome tagged antibodies against these proteins, CD55, 59, and again for the CD24, 14, and these are all the proteins present on the neutrophils and monocytes, right, respectively, right? So these will give antibodies to these proteins, and when these when these proteins are absent, the antibodies won't bind and fluorescence won't come, right? So we can detect the PNH patients, correct? Right. So in the PNH, in the flow cytometry, this flow cytometry is the most sensitive for the diagnosis and even for the monitoring of this PNH. Why? Why? Because the size of the PNH clone is best determined by the flow cytometry. Okay, that's why it is most sensitive, and most even monitoring, for the monitoring, this is most useful. Okay. Then, so what is the rule here? Yes, we all know this is rule of 2. So what is this rule of 2? We should check 2 lineages, that is RBC and WBC. And among this WBC also, we should check 2 population of WBC, that is neutrophils and monocytes. And in these 2 population, each population should check for 2 markers. Okay, so we should check 2 lineages, RBC, WBC, 2 different lineages, and within the lineage, you should check 2 different population, that is neutrophils and monocytes, and each population should be checked for 2 markers. So that is rule of 2. Okay, this is a criteria given, okay, for the diagnosis of PNH. Yes, so again, the most important stage, more prone to error stage, that is pre-analytical variables. So we should know about this, right? Again, it's a repetition, right? I want you guys to answer, okay? So what is the type of sample? We'll use peripheral smear or bone marrow? Yes, we'll use peripheral smear, right? So bone marrow, it is not used for the flow cytometric assessment in PNH. Peripheral smear is used. Okay, then what is the anticoagulants used here? Anything, right? EDTA, we can use EDTA, we can use heparin, or we can use acid citrate dextrose, ACD, any anticoagulant we can use. Then what is the sample volume? How much amount we required? How much amount we required? Okay, it is 3 ml. 3 ml is adequate. What is the minimum amount we should need? Minimum amount is 1 ml is minimum. Okay, 1 ml is minimum. Then what is the sample age? Then that means after collecting the sample from the patient, within how much time we should run the flow? Okay, we are doing for 2 population, right? So for WBCs, how much time? We should run within 48 hours. More than that, the WBCs will undergo degenerative changes, will undergo degeneration. That's why within 48 hours, we should run the sample. And for RBCs, yes, you are correct. It is within 7 days, within a week, less than 1 week, we should run the sample. So it's not like dictum of within 7, after 7, like within 1 week, I should run the sample. We should run the sample as soon as possible. But these are the major maximum limits. Okay. Then what is the temperature if you are storing? If you have where you have to store, what is the temperature that you have to store? Right? What is the temperature? It is 4 degrees centigrade. Sorry. So it is 4 degrees centigrade. So if the sample is more than 24 hours after collection, so we should store it at 4 degrees centigrade. Okay. So what is the lysing reagent we should use here? What is it? Yes, it is ammonium chloride. Okay, ammonium chloride. So what we are lysing here? What cells we are lysing here? Why we are lysing here? Yes, why we are lysing here? So what we are lysing here first? We are lysing the RBC. In which analysis? RBCs are lysing in WBC analysis. Why we should lyse it? Because RBCs are in millions, right? They can interfere with the WBC. WBCs are in thousands. Okay. So in RBC, in WBC analysis, these RBCs in millions, which are in millions, they can interfere with this WBC analysis. That's why we are lysing them. Right? In RBCs we are lysing them. Okay. The lysing reagent is ammonium chloride. Then what is the sensitivity of the flow? What should be the sensitivity? Minimum what should be the sensitivity? It should be 1%, right? That means 5,000 cells, 5,000 events. That means we should count at least 5,000 cells to determine the PNH in the patient. Okay, minimum 5,000 cells should be there in the patient sample, and that gives a sensitivity of 1%, which is the minimum. Minimum should be there. And what is the maximum limit? What is the maximum percentage sensitivity? It is 0.01%. Okay, so this so here 0.0, that means you are calculating 250,000 events. Okay. So if you are seeing the PNH clone in more cells, the sensitivity will increase, right? So the sensitivity is 0.01%. That much sensitive the test will be. Okay, that is the maximum sensitivity you can get. But minimum you should do 5,000 events. Why? Because PNH is associated with certain conditions. Yes, what are they? Yes, it is associated with aplastic anemia or aplastic anemia. And it is associated with MDS, correct? Where there will be cytopenias will be there in the peripheral smear. We are not using bone marrow sample. We are using the peripheral smear sample. Where in aplastic anemia and MDS, the peripheral smear will show pancytopenia, right? So where we will not get cells only. So, but even though you should try to get at least minimum 5,000 events, so that the sensitivity of the test will be 1%. Okay, that's why. Then. So yes, we already said there is rule of 2. We should check the RBC, WBC, but routinely what analysis we should do? Is it RBC or WBC analysis? Yes, you are correct. It is WBC analysis. We should do routinely. Routinely we should do WBC analysis. Why not RBC? Yes, why not RBC? Because if the PNH, the patient is undergoing chronically, there is intravascular hemolysis, right? And the patient having anemia, he might be receiving RBC transfusions. So because of this chronic hemolysis and RBC transfusions, whatever we are counting the RBCs, if you do routinely, that may be underestimated. Like that means underestimation of the PNH clone can happen. Because the patient may be the RBCs that may be lysed, or the patient can receive transfusions. So in that time, what will happen? The PNH clone will reduce, right? So there will be underestimation of this PNH clone. That's why we will not routinely do the RBC analysis. So what we'll do here, initially, first we will do the WBC analysis. First, we'll do the WBC analysis. If PNH clone is detected, if PNH clone is positive, then we'll go for the RBC analysis. Okay, then we'll go for the RBC analysis. If PNH is not there, if it is PNH is negative, then we'll stop the test. No need. There is rule of 2 is there, but if WBC is normal, then there is no point of going to next lineage, right? So that's why if PNH clone is positive in the WBC analysis, which are routinely done, then we'll go for the RBC analysis. Okay, then. So again in the WBC analysis, which population? We already discussed, it is neutrophils and again monocytes. Again rule of 2, we should check for 2 population, right? 2 is in the lineage, you should check for 2 population, neutrophils and monocytes. And yeah, can lymphocytes can be studied? Yes, can be studied, yes or no? Yes, you are correct. It is no. We should not study the lymphocytes. Why? What is the reason? 2 reasons are there. Yes, anyone remember? Yes, they have long lifespan. What will happen if lymphocytes have long lifespan? What is the reason? Why should not check it? Why? Because this PNH is a acquired condition, right? PNH is acquired, right? So it is developed during the this life of the patient. During the life of the patient, the PNH is developed. But these lymphocytes, they have produced before the birth. They have very long lifespan. So if you do the lymphocytes, which are absolutely normal, the pyrogen will be normal. So we label the patient as absolutely normal, even though the patient has PNH. Okay, that's why. And what is another more reason? They show variable expression of the markers. They show variable expression of the markers. So they won't show constant expression. Sometimes they'll show positive, sometimes negative. That's why because of these 2 reasons, we should not do the lymphocytes population, study of this lymphocyte population in the PNH. We'll only do the neutrophils and monocytes. Then what are the gating markers? Yes, what are the gating markers? Gating markers means how will you separate these neutrophils and monocytes normal in flow? Yes, it is CD45 versus site scatter, right? Where the highest site scatter, neutrophils have high site scatter and monocytes have low site scatter, so they will get separated. And what is the another most important gating marker, which is very specific for particular cell, which is for monocyte? Yes, it is CD33 versus site scatter. CD33 are bright positive in monocytes. Monocytes are bright positive for CD33 and site scatter is high in, as usual, in neutrophils. So they will get separated. These are gating markers. So we are separating the population, two population, right? Then what are the PNH specific markers? So we have to detect the PNH, right? The specific markers means whatever the GPA anchored proteins, they are the specific markers, right? Because the GPA in PNH, the GPA anchored proteins are deficient. So if we use those specific, the GPA anchored proteins as antibodies, and we can detect those markers, right? So what are those antibodies we should use for neutrophils? Yes, it is CD24. And one more, flare. Okay, for monocytes it is CD14, yes, and again flare. So here the flare is the any marker, any GPA anchored protein? No. What is this flare? Flare is fluorescent aerolysin. It is a toxin which is produced by the bacteria Aeromonas hydrophila. So why we are using this flare? Why we are using toxin here? Because what will this toxin do? Normally this toxin, it will go and bind directly to the GPA anchor, not to the GPA anchored protein. Remember, the GPA anchor is a GPA moiety. Itself is a protein, it's a moiety. It is holding some different protein. Okay, so here in neutrophils and monocytes, we are checking the CD24 and CD14. They are the GPA anchored. These are GPI anchored proteins. These are the proteins which are attached to this GPI moiety. Okay, so and these proteins are defective in PNS. So we are using the antibodies against these proteins to detect these proteins are present or not. But this flare, this is a toxin which will go and bind directly to the GPI. So in PNH, GPA won't be there, right? So the GPA won't be there, then this flare won't go and attach to this, so we can detect. And why we are using two markers? Again, rule of two. We should always do, at least in each population, we should do two markers. Okay. Then what is the common marker for both these? Yes, it is CD157, which is another important marker. And remember, without flare, that means flare, it is mandatory. Okay. So you cannot do CD24 and CD157 together. No. Flare is mandatory. We should do flare. It is mandatory in any. You should do flare CD24 or flare CD14 or flare CD157. This combination should be there. Flare is mandatory in any of the combination. Okay. Then for the RBC analysis, yes, RBC analysis, what are the gating markers? Yes, here it is site scatter versus forward scatter. But remember which scale? It is logarithmic scale. That is important. RBCs, they won't see in the linear scale. They will be visible only in the logarithmic scale. That is very important. Then what is any specific marker? Yes, you are correct. It is glycophorin A. All these are discussed in PNH already. Okay. Yes. So glycophorin A is the marker. And what is the CD name for it? CD235 alpha. Right? CD235A. So these are the gating markers. And what are the specific markers? It's easy, right? The complement proteins, right? That is nothing but CD55 and CD59. Okay. Which is DAF and which is MIR? What is the highest number? They have highest words, right? So CD59 is MIRL. MIRL is nothing but membrane inhibitor of reactive lysis. Okay. And CD55 is DAF. DAF is decay accelerating factor. Okay. These are the complement regulatory proteins. Okay. Then what is the crucial step? Yes. What is the crucial step? Yes, it is washing. Washing is the crucial step. We should wash the sample. Why we should wash the sample in RBC analysis? Because RBCs are in millions. Okay, yes, they have negative charge on their surface, so they won't adhere to one another, but they will group together, right? They are in millions, so they will always go in groups. So if you don't do this washing step, what will happen? So see here, this is the CD59 marker which is done in a patient. So before, if you don't do the washing, what will happen here? Everything. Again in RBCs, how many populations are there? 3 types of populations, right? Which population is normal? Type 1 or type 3? Yes, you are correct. Type 1 is normal. Type 3 is abnormal. Correct? So if you don't do washing, see here, we'll do the test without washing. Everything is coming as type 1 and we'll label this patient as absolutely normal. But the same patient after washing, see, can you see here? There is 2 populations are there. Type 1 is there and again type 3. See, and majority is type 3 only it is there. So, where if you don't do the washing step, we'll label the patient as absolutely normal, even though the patient is a PNH. Okay, that's why the washing step is very, very, very important. Okay, and we'll do the lysing step here in RBC analysis. No, right? Because we are checking for the RBCs only. No need for lysis. And because no need for lysis the WBCs also, because WBCs are in thousands only. They can't interfere with the millions. Okay, so there is no lysing step. There is no lysing step. Okay, yes. So here I kept the differences table. Same thing we discussed in the PNH. I want you guys to answer now. So what is the routine analysis we'll do? WBC or RBC? Routine analysis we'll do the WBCs, not the RBCs. Why? Because RBC undergoes hemolysis. Okay, RBC undergoes hemolysis and the patient will be routinely on the RBC transfusions, red cell transfusions. That's why the routine analysis is WBC, not the RBC. Then lysing step is done in which one? In WBC analysis, lysing step is done. Because we are lysing the RBCs here, they are in millions, they can interfere with the WBC analysis. That's why we are doing here. Lysing step is not required in RBC analysis. Then washing step is required in which one? It's very crucial step in RBC analysis. It is not required in the WBC analysis, washing step. Then gating strategies, that means which scale? In our WBC analysis, which scale we'll use? It is linear scale, correct? Linear scale. And here we'll use logarithmic scale, right? Yes, here we'll use logarithmic scale. Then gating markers, WBC analysis, yes, it is CD45 versus side scatter, and one more which is specific for monocytes, CD33 versus side scatter. Okay, then what is the gating mark for RBC? It is side scatter versus forward scatter, again logarithmic scale. Then in the specific marker it is CD235A alpha or glycophorin A. Okay, then what is the PNH specific markers in WBCs? For neutrophils it is CD24 and flare is mandatory. Then for monocytes it is CD14 and flare. And what is the common marker? Common marker CD157, correct? Then for the PNH specific for RBC it is CD55 and CD59. Here again one more important, among these two which one is more important? 59 or 55? 59 is more important. Okay, 59 is more important. Then so here I kept the graphs. Yes, we'll analyze. These are the three most important graphs we already discussed in the previous class, that is flow cytometry basics. Yes, what is this graph? Yes, this is acquisition, right? This is the acquisition, where it is acquired over a period of time, right? So here, as we see, there is no breaks, nothing. So the acquisition is proper, correct? Acquisition is proper. Then this graph, yes, this is singlet population, separating the singlet from the doublets and triplets. This is forward scatter area versus height. So these are the population having more area. So these are the doublets and triplets. So we are getting only the singlet population. Then what is this graph? Yes, this is viability graph, correct? Yes, this is viability graph. You are absolutely correct. So here forward scatter and side scatter. Which are viable cells? Having the cells having high forward scatter and low side scatter, correct? Low side, those are viable cells, right? So these gates, see, high forward scatter and low side scatter. These are the viable cells. Then comes our main gate, which is CD45 versus side scatter. Here we are separating the WBC population. Yes, these green ones, what are these? These are, yes, you are correct, these are monocytes. And what are this population? Having high side scatter, these are neutrophils, correct? And here we can use the specific marker for monocytes, which is CD33. So CD33 and side scatter, as we see, these are the monocytes. See, this CD33, they are very bright positive. You can see they are coming at very high end, almost 10 to the power of 4. Okay, these are monocytes which are bright positive, CD33 bright positive, and these are dim to negative, and but their neutrophils have very high side scatter, right? High side scatter. So, and here, this orange population is nothing but neutrophils. So what are the gating markers? Neutrophils. See, again say CD24 and flare. I said flare is mandatory. Okay. So CD24 and flare. And both the markers are expressed or not? Yes, this quadrant 2 is nothing but double positive. Right? We already discussed this. This is double positive. Then this one, green population, nothing but monocytes. Then what are the markers? CD14. See here, CD14 and flare. Right? So it again comes in the double positive zone. Right? So this flow, whatever flow is showing, the patient is a normal or PNH? Normal or PNH? Yes, you are correct. The patient is absolutely, this is normal. So the patient is normal. Okay. Next, we'll see another graph. Again the same thing, acquisition graph time, and acquisition is proper acquisition. Yeah, proper acquisition. Then again singlet population, again viability gate. Okay. Then the main graph, CD45 versus side scatter. You have to tell me what is this green population? These are, yes, these are neutrophils, and this blue population are again monocytes, correct? And here CD33, which this population bright positive, again the blue ones, they are monocytes, and the green ones, the high side scatter, they are neutrophils, correct? Now here, this one, what is this orange population? Any orange population I have seen here? No. What is this orange population? Nothing but the previous graph, this one. So the orange population are nothing but here, these are neutrophils. So this is always, we already discussed this, always we should interpret flow along with the normal population, normal control population. That means either you should know where the normal population lies, first thing, or we should always compare with the normal population gate. We should keep the gates below or anywhere. So we should compare the before reporting the entire flow, correct? So here I kept this because so we can understand this is a normal neutrophils. Here the neutrophils show, here they are showing both positive. This is double positive, right? But our population, in this flow, what are our neutrophils, actual neutrophils? Green population are our actual neutrophils, okay? So where this green population is coming, see, this is both negative zone, double negative zone, right? This is double negative zone, this is coming. That means flare is negative, CD24 is negative, which is not expressing on the neutrophil population, right? Again, monocytes, here the green one, in the previous one, see the green ones are the monocytes. So this is the control, okay? This is the control. Okay, so the blue ones in this patient, the blue is the monocytes. Where this monocytes are coming? Again in the double negative zone it is coming. So both flare and CD14 is negative. So this is patient or this is PNH patient or normal? Which one? This is PNH. Okay, this is PNH because the flare is absent. That means GPI anchor is not there. Then the GPI anchored protein CD24 and 14 both are absent. So the GPI anchored proteins are also absent. So the patient having PNH. Okay. Then what is the next step? First, we'll do the WBC analysis. WBC PNH clone we have detected. What is the next step? Right? What is the next step? Next step is the RBC analysis. Right? RBC analysis. Okay. So, here in RBC analysis, which markers we'll check? CD55 and 15, and among those two, CD59 is better marker, right? So, here CD59. See, and here this is normal or abnormal? Can you see this is, where is the type 1 population, type 3 population? Type 1 population will lies to the extreme right and type 3 will lies extreme left, right? So, this is type 1 population. So, type 1 is everything, entire population is type 1. So, almost 95% is type 1. So, this is normal patient, okay? And again, control, we should always compare with control. And here, this is the, can you see? This is which population? Extreme left. So, this is type 3. And the normal cells, almost 86% are type 3 population, only 13% are type 1. So, this is PNH patient, the same patient we have done, because there is rule of 2. We have to, before confirming, we have to do 2 lineages analysis. So, RBC also showing the PNH, WBC also showing the PNH, right? But there is a cutoff they have given. So, what is the normal? Normally, this PNH, that means absence of these markers, it should be there less than 0.01% of cells only should show absence of these markers. Then only it is normal. If this PNH markers, whatever this specific markers, they are absent more than 0.1 to 1%, then it is minor clone. If more than 1% of cells, it is showing absence of these markers, then it is major clone. Here 86% of cells showing absence of this CD59. So it is a very big clone, very major clone, right? Yes. So what is this PNH? What is which type of PNH? Yes, this is, yes, it is classic PNH. Correct? There are 3 types, right? Classic PNH, PNH associated with underlying bone marrow disorder, and subclinical PNH. So here majority everything is type 3. This is a classical PNH, classic PNH. What is the treatment? Yes, what is the treatment? Yes, it is eculizumab, which is a eculizumab. So this is a C5a inhibitor, right? Complement inhibitor, eculizumab. Okay. Then, yes, we are done with the one disorder of the RBC. Next, we will go with the flow OFT. Again, it's a repetition. Yes. So flow OFT is the mechanism is same like normal OFT, but the method what we are doing is little different. Yes. What is this? Again, this is the time is there. So it is acquisition graph. So we are counting the cells. Okay. We are counting the which cells? RBCs here. Okay. Right. So we are counting, and the count, the first count is around 18,000, second is also 18,200. Okay, then what we did here? We already discussed in RBC membrane disorders. Same thing. DI is, yes, it is deionized water. Right? Deionized water. Nothing but distilled water. So we are adding it. Right? We are adding it. Then we are acquiring the cells. We are counting the cells again. So we are counting for 8 to 10 regions with an interval of gap between 11 seconds in between the regions. Okay. Then at the end of the 10th or 11th, here 10th region count they have given. How much is the count? The acquisition is around, count is 7,000. So more than 50% of the cells they are lysed. Concept is same. When we add the deionized water, it's an osmosis, higher concentration, lower concentration, water enters into the RBCs. Then RBCs after withstand for some time, then they will lyse. Okay. So the final count will be 7,000 here. It is for more than 50% has been lysed. Okay, this is the control sample. Okay, this control sample. In HS patient, in RBC membrane disorders, a HS patient. So this is the first population, the initial baseline acquisition, baseline count. Then they have acquired. Can you see here? Almost more than here the gap is nothing but here deionized water spiking. Okay, deionized water spiking. Okay, spiking is done in this gap. Okay, then you can see again the regions has been, acquisition has been taken. See, more than 50% they have lysed in the first itself. Okay, and at the end of the region only 10 to 20% only remained. 10 to 20% only remained. Okay, so we can see clearly here. Can you see? It's reduced, but still some cells are there. Okay, but if you see here, almost 80-90% they are gone. Okay, but this is subjective. So, but we need some objective measurements. So that's why there are 2 objective measurements. Yes, residual red cells. Yes, can anyone tell the formula? Yes, it is the last 2 regions, mean events of the last 2 regions, that is P9 plus P10, the mean of these 2 region count divided by the initial first count, that is P1 into 1.1 divided by 2 into 100%. So how much cells should be there? If how much it is less, then it is called it as HS patient. Yes, it is. If the percentage, the residual red cells, if it is less than 16.29%, then the patient having HS. Okay. Then one more parameter. Yes, that is residual red cell ratio. Here, what is the ratio? Ratio of normal or control or a patient above. So it is the residual red cells of normal or control divided by the residual red cells of patient. So obviously the normal will have more. The little more, the denominator is more, denominator is less, so the ratio will be more. How much more? What is the percentage? Yes, it is more than 1.72%. So, if the RRC ratio, if it is more than 1.72% and residual red cells, if it is less than 16%, then both are diagnostic of HS. Correct? Yes. Then, EMA binding test. Yes, again repetition. This is third time we are repeating. What is this EMA? It is eosin 5' maleimide. Correct? Yes. So, what is this EMA will do? What is this dye will do? It will bind to which amino acid? Yes, it is bind to lysine amino acid. At which position? Yes, it is 430 position of this band 3. So any band 3 abnormalities, so there will be reduced fluorescence. Again, normal control. Always will run with normal control. So the fluorescence is this much. Normally the fluorescence should be this much. But in HS patient, wherever the spiro, not only HS, other conditions. What are the other conditions other than HS? Yes, it is Southeast Asian polycytosis. Correct. Then another one, very important one. Yes, CDA type 2. Correct, CDA type 2. And one more, cryohydrocytosis. Cryohydrocytosis. This one also. Okay. Yes, in all these where spirocytes are there. Okay. They were not. It's not about spirocytes. Where band 3 abnormalities. I'm sorry. Band 3 abnormalities are there. Say we'll see this reduced fluorescence. How much reduced fluorescence in HS specifically? What is the MFI? It should be less than 0.8. Correct. More than 0.8 is normal. If it is less than 0.8, then it is HS. And in CDA type 2. Yes, CDA type 2. What is the MFI? In CDA type 2. What is the MFI? Yes, it should be less than 65% of normal. Then it is CDA type 2. Correct? Yes. Okay, and then one more, it's out of the topic here. How will you differentiate these two? We already discussed in CDA, HS and CDA type 2. How will you discuss which marker? Yes, you are absolutely correct. It is CD44. This is the marker which is present in which one? It is positive in 96% of cases. It is positive in the CDA type 2. Okay? Yes. Then, so flow in the other disorder, G6PD disorder. So G6PD deficiency, yes. Here it's the concept, the mechanism is same like methemoglobin reduction test. Only certain 2 steps are extra. Okay. So same methemoglobin reduction test. So we'll take the patient blood, we'll add the sodium nitrate. Yes, in methemoglobin reduction test also we'll do the same thing. So what the sodium nitrate will do? It will convert the oxyhemoglobin to methemoglobin. Correct. Then what we'll do add in methemoglobin reduction test? We'll add methylene blue. Right. We'll add methylene blue. And one of the alternative for this methylene blue is Nile blue sulfate. Both have same action. What is this? What is the action? Now they will stimulate the HMP pathway. HMP pathway is stimulated. Correct? So when this HMP pathway is stimulated by this methylene blue or Nile blue sulfate, what is this response? Yes, you are correct. This is pharmacological response. Right? Pharmacological response. What is the physiological response? Which enzyme? It is cytochrome B5 reductase. Yes, very good. So this when this pathway is stimulated, if the person has normal pathway, okay, G6PD is absolutely normal. If the person is normal, then what will form? Again, this methemoglobin is converted back to oxyhemoglobin, correct? And if the patient is G6PD deficient, then this methemoglobin persists. Till here it is methemoglobin reduction test, same. Next, here the difference comes, only 2 steps difference. What is that? Here, next what we'll do, to the same sample, we'll add the potassium cyanide. Okay, so here you should know this potassium cyanide, it will react with only methemoglobin. Only methemoglobin reacts with this potassium cyanide. Okay, not the oxyhemoglobin. So if the patient is normal, he forms the oxyhemoglobin. The oxyhemoglobin, it won't react. That oxyhemoglobin won't react. So oxyhemoglobin persists. But with hemoglobin, it will react with potassium cyanide and it forms the cymeth hemoglobin. And this cymeth hemoglobin is non-fluorescent. Okay, it is non-fluorescent. So we are detecting with the help of flow cytometry. So whatever we are doing at the end, the fluorescence should be there, right? That is the basic concept. So this cymeth hemoglobin, it is non-fluorescent. So, but then second step is the H2O2. We'll add the H2O2. And this H2O2, it only the oxyhemoglobin reacts with H2O2. Okay, the methemoglobin won't react. So the oxyhemoglobin reacts with this oxyhemoglobin reacts with H2O2 and then it forms the feryl hemoglobin and this feryl hemoglobin is fluorescent. Okay, so here if the feryl hemoglobin is formed, feryl hemoglobin is fluorescent. That means the patient is normal or abnormal? The patient is here normal. Understand here. Because this feryl hemoglobin is when it is forming. It is forming when there is oxyhemoglobin. So for the oxyhemoglobin to be present in the sample, the G6PD should be normal. Then only oxyhemoglobin will form. Then after that this oxyhemoglobin reacts with H2O2 and the feryl hemoglobin is formed, which is fluorescent and detected by the flow cytometry. So if the fluorescent sample is there, then the patient is absolutely normal. And if the non-fluorescent is there, that non-fluorescence is because of cymeth hemoglobin, and this cymeth hemoglobin, it formed when the methemoglobin reacts with the potassium cyanide and the methemoglobin is persisting. That means the patient is G6PD deficient. Okay, so then with the non-fluorescent sample, if it is there, then the patient is G6PD deficient, G6PD negative. Okay, then so the same graph here, don't go by the color. This one, see the fluorescence here. This one, whatever this blue color one, the fluorescence is very high, around 4.5 it is coming. So this fluorescence is more. That means which hemoglobin is there? Here it is feryl hemoglobin is there. Feryl hemoglobin means that is oxyhemoglobin is present. That's why it is reacted with this H2O2. It reacts with the H2O2 and it forms the feryl hemoglobin and that gives the fluorescence. So this is normal. Okay, and here this one, the white ones, this is the cymeth hemoglobin. Because fluorescence, see the fluorescence here. Fluorescence is less, right? Because the fluorescence is less, that is non-fluorescent one is the cymeth hemoglobin, which is formed by the methemoglobin by reacting with potassium cyanide, KCN. Okay. So here, based on this, the fluorescence is more, then the patient is normal. The fluorescence is less, and this is G6PD deficient. Right? Okay. G6PD deficient. This is how we can use the flow in G6PD deficiency. Then the last one in the RBC disorder, that is reticulocyte count. There are enumeration of this retic count with the flow. Okay, so we know the retics, they have what they have. Reticulocyte will have rRNA, right? rRNA, right? Retic will have rRNA, and this rRNA will use the dye, that is thiazole orange dye, which reacts with this rRNA and they will give the fluorescence. Normal RBCs, they won't have rRNA, correct? And so this they won't react, and thiazole orange dye, it will react with this rRNA of the retic and that will give the fluorescence. Okay. Same thing again, time graph is acquisition, so acquisition is absolutely normal, proper, there is no gaps, nothing. Then here we are getting the RBC population. On which scale this is? Yes, it is logarithmic scale. Again important, even if you do linear scale, RBCs won't get highlighted. This is logarithmic scale for the forward scatter and side scatter, and the RBC population is highlighted, and we are getting this RBC population for this against the thiazole orange. Okay, so whatever the stained ones here, these are the reticulocytes. Okay, because they have RNA, and this dye will go and react with the rRNA of the reticulocyte, and that will give the fluorescence. And these population negative ones, these are nothing but these are RBCs. Okay, so why we have to do the enumeration of this retic? Yes, because retics are very important, because we can know the cause, we can know the marrow response. If there is anemia, if the marrow is responding nicely and the retics are increasing, that means see the reticulocytes are more, and this rRNA, this content of this rRNA, it is more in immature retics. Again, in retics there are 4 stages, right? Reticulocyte, we already discussed this. Yes, so these immature retics, they have more RNA content, this RNA more in the immature retics. Okay, so the immature reticulocytes are increasing, and finally all the reticulocytes are increasing. That means what's happening? There is hemolysis, which is a hemolytic blood picture. So hemolysis is happening. Okay, so we can know the cause. The patient is having hemolytic anemia. Okay. Then if the retics are low, retic count is low, and the immature reticulocytes, even the marrow is not producing, so the outside is also less. So that means there is aplasia in the marrow, right? So the aplasia, it may be aplastic anemia, or it may be pure red cell aplasia, anything. So there is aplasia, the marrow is not responding. So we can know the causes. Okay, or if the marrow is responding, there is marrow hyperplasia, but in the peripheral smear, there is cytopenia. So what is this? Yes, we already discussed in CDA, this is nothing but ineffective erythropoiesis, right? So we can detect that also, right? If you do the marrow there is marrow is hypercellular, but the retics are less. So we can detect with this reticulocyte count, we can detect this ineffective erythropoiesis as well, where there will be reticulocytopenia, but marrow will be hypercellular, correct? So for all these causes, we can detect by doing the retic count by doing the retic enumeration in the flow cytometry. Then, okay, then we are done with the RBC disorders. Next, we'll discuss the WBC disorders. What are the WBC disorders?